Very good morning to all, and thank you organizing team BRiCC 23 for having me here today. I think we've had two excellent sessions that I've been sitting through, and part of continuation on the topic, the gastrointestinal tract. I think we can't miss out the liver. The liver is such an important organ, and this topic is something that we frequently encounter. How many of you have managed an acute liver failure? So quite a number of hands, and you all would agree with me, it's a big challenge. It's a big challenge, and we will ultimately end up in, getting a transplant in most of these patients. So I think it's a very important topic. I'll try to keep it as brief as possible because of respect of time. So an overview of this presentation, I will have a quick look at what is the definition and the epidemiology, especially in India, of acute liver failure. A relevant clinical history that is very important in these patients. What are some important clinical examination that you should look for? Specific treatment in some instances of acute liver failure, organ support, and finally liver transplant. So we all know what's the definition of acute liver failure. Very simple. No major numbers like abdominal compartment syndrome that you should be remembering. It's nothing but an acute derangement of liver function with this triad of presentation. You have jaundice, you have a coagulopathy. Coagulopathy I mean in terms of INR, the prothrombin time and the INR. There is a derangement in the value and the patient presents with an encephalopathy. So these are the three cardinal signs of acute liver failure. But because it's an acute, we need to take into consideration the time frame. So when I look at the time frame, it is from the onset of jaundice, because jaundice is the initial symptom in an acute liver failure. And how soon does the patient develop the encephalopathy? So anyone knows this classification? I'm sure there are several definitions that you must have when you Google and you are reading. There are several definitions for acute liver failure. Any idea what's the name for this one? O'Grady. Okay, so O'Grady and his colleagues proposed this definition way back in 1996. So it's from the time of jaundice to the onset of encephalopathy. If it happens within 1 week, it's hyperacute. So this all encompasses acute liver failure. But to intervene early, to identify and enroll for probable liver transplant, this classification is very, very vital. You can't just say this patient is acute liver failure and sit quiet, because you need to assess, prognosticate and plan quickly in these patients. So hyperacute, that is within a week. If it is 1 to 4 weeks, it could be given in days or weeks. I am mentioning it in weeks. 1 to 4 weeks, that is 8 to 28 days is actually your acute period. And anything from 8 to 12 weeks is subacute. Because some cases of acute liver failure, they actually present as a subacute. So you should know this poisoning or this drug overdose or this infection, I could expect my deterioration in the hyperacute or acute or subacute. So that's why this definition is very vital. And something that goes on beyond 12 weeks, or if I say 28 weeks, then I would say it is a case of chronic liver disease. No longer I would put it into the definition of an acute liver failure. So acute means we are all used to days, few days, right? But when it comes to ALF, it goes up to weeks. So this is your definition of acute liver failure. Still the burden of ALF in India is not known because of the poor reporting system, the registry, non-availability of reporting in different centers. So this is quite an old study that is there in NAGM in 2013 that was proposed. And later on in 2020, this was the only kind of information that I was able to retrieve from the available literature. So the exact burden is unknown. The etiology is quite different from the West. So when you Google and you say what is the commonest cause of acute liver failure, what highlights in the Google search? Paracetamol, but that's not so in India. It's quite different. It's not paracetamol that is the primary cause in India. It is viral hepatitis. Okay, so the viral hepatitis is the most common cause in India, especially E. India is actually hyperendemic. Okay, so this is from the 2020 article that was published. So now very limited literature of publications of what are the common causes of ALF in India. And the second common cause, you won't believe it, is drug-induced liver injury, especially our anti-tuberculous drug. Because tuberculosis is still rampant in India, and so delay due to ATD is a second most common cause, and definitely other drugs. What do you think the other drugs could be in India? Alternative, yeah, Ayurvedic medicine. So alternative medicine. So that's the second most common cause, like tuberculosis, anti-tuberculosis drugs, or the alternative drugs. And mortality, if you don't manage it, recognize it early and manage it appropriately, can be as high as 80%. Okay, and this would depend definitely on the etiologies or host factors and the care that you provide. So that also is very, very vital. That will determine your outcome. So let's go straight away into the management. History is very, very, very important. Why? You definitely need to know what is the etiology, right? You will not know the etiology unless you obtain the history. The patient may just present with a jaundice encephalopathy. You will need to find out what is the reason for this acute liver failure. So detailed history for possible etiology of ALF cannot be debated. Okay? And you need to ask history of fever. History of fever would give you a clue. Is there an infectious etiology? Drug usage? Is there a possibility of a drug overdose or deliberate self-harm like a hepatotoxin injection? And family history, especially when you're looking at Wilson's disease. History of blood transfusion. Why would you want to ask history of blood transfusion? Sorry? Yes, you're right. Yes, hepatitis B. So any previous history of blood transfusion, it would give you a clue. Am I dealing with hepatitis B infection and any other chronic health problems that he could be taking multiple medications? So these will all give you a clue to what could be the etiology. Timeline of the illness is also important, as you already know from the previous slide. You need to put it into the definition of acute liver failure. So the timeline is also very important. Clinical examination, when it comes to, you have a patient, yes, he has jaundice, but you need to further examine to see, has he got the subtle signs or early signs of hepatic encephalopathy. Okay? So the cardinal signs of ALF, yes, jaundice and altered sensorium. You can't just get the patient straight away in an altered sensorium. There will be subtle signs like asterixis. So you may need to identify it early. Okay, and fever the patient disturbed, right? Vitals. Why would the patient have these vital signs? Bradycardia, hypertension first, raised ICP. Okay, so there could be signs of raised ICP, but ALF as such, the presentation is with hypotension. Why? Why do they have hypotension? They won't have an abdominal compartment syndrome here and such here. It's a vasodilated state, okay, and they could present with a multi-organ failure and inflammatory response. So there could be hypotension and shock. And if there is hyperventilation, what would you suspect? There's a hepatic encephalopathy, right? So these are some important signs that you need to look when you are examining. The patient is not going to tell me that I am hyperventilating. So you need to pick up these signs when you are examining the patient. There could be hepatomegaly with pain in the right hypochondrium. And if the patient has been sick for a while, not in the hyperacute phase, with leading to already low albumin synthesis, they can have a peripheral edema. So these are very important clinical signs, which is also vital in your management. You cannot go straight away into drug therapy without having taken a good history and examined the patient. Relevant lab investigations are also vital. You will have an INR because coagulopathy, more than 1.5 to define it. There could be thrombocytopenia that could be setting in because of the liver dysfunction, elevated liver enzymes with bilirubinemia, hypoglycemia. That's another very, very important sign in an acute liver failure. So if you have a patient who has hypoglycemia, he's got jaundice, so that could give you a clue. Yes, my liver functions are very much deranged, leading to hypoglycemia, and you need to closely monitor these patients for the glucose control. So because these patients can frequently present with hypoglycemia, so in the intensive care unit, you need to monitor the sugars. They'll have lactic acidosis because of impaired metabolism of lactates. That there could be high ammonia levels, which will indicate hepatic encephalopathy. They can develop hepatorenal syndrome. So many of our patients with acute liver failure are bound to develop hepatorenal syndrome, especially if there is progression of acute liver failure. Dyselectrolytemia in the form of hyponatremia and hypokalemia is quite common, and you need to work up for viral hepatitis because you need to identify the etiology. You are not getting any other causes. So this is in brief the lab investigations. You need to do sometimes an imaging also in specific conditions. Anyone can identify what's the abnormality here in the image here that's given the CD? Okay, I'll put the arrows. There's something sitting there in the vessel. There's a thrombus there. So what is it? Portal vein thrombosis. So this is another common presentation of acute liver failure. So you may need to do some appropriate imaging to find out the etiology if you have not yet identified. So treatment, yes, all these patients need to be admitted in the ICU. There's no doubt about it. I don't think these patients can be monitored so closely outside the ICU. In the ICU, first is supportive care. You need to prevent and manage complications. They develop multi-organ failure, and specific treatment if you have identified the etiology. If our medical management fails, you may need to provide liver support, and liver transplant has to be considered. So this is your, in brief, the treatment. So when it comes to supportive management, as I have already mentioned, the GCS has to be monitored. The blood pressure can be very labile, so you need to monitor the blood pressure and the blood glucose. An NG tube has to be inserted so that you can start early enteral feeding. Maintain normovolemia. Normovolemia is very, very important, and the blood pressure has to be maintained with norepinephrine. If required, you can add a vasopressin if there is an ongoing GI bleed and you are suspecting already the development of varices. Higher MAP target of 75 may need to be considered, especially if there is hepatic encephalopathy with raised ICP. Or if the patient has a pre-existing hypertension or the development of HRS, you may need to consider a higher MAP. Airway protection will, obviously be the need of the hour because the patient would be having a hepatic encephalopathy. Stress also prophylaxis because the patient may have a coagulopathy, so there may be the need to start stress also prophylaxis also. How many of you have used NAC for acute liver failure? Do you commonly routinely use for all patients with ALF or only with paracetamol? All patients, yes. The evidence now is favoring NAC for not just for paracetamol, for all other conditions of ALF. Initially, there was only for drug-induced ALF, but then evidence, especially in the recent meta-analysis that was proposed in 2021, has said that there is evidence even for non-paracetamol ALF also. So you are all aware of this loading dose. I'm sure even in your sleep you will mutter out this dosage. So this is the meta-analysis. If you see, the odds of survival is in favor of NAC for all causes, but it's not a very great meta-analysis. If you see, the total number is only 472 patients. But yes, so this does say yes, and NAC is harmless. You can give, except for the volume, it is harmless. So you should be offering NAC for all cases of acute liver failure. So the moment the patient comes to the ICU, start NAC until you get the history and the tests for the etiology. Neurological complication is the most dreaded complication because these patients can develop severe hepatic encephalopathy with raised ICP, and it is one of the cardinal signs of ALF. And if it's a rapidly progressing, hepatic encephalopathy in ALF is a very poor prognostic sign. But in subacute liver failure, even mild derangements in your consciousness or early stages of HE is very, very poor prognostic sign. So this is something that you need to keep in mind because you may need to have your goals for therapy accordingly, and you need to prevent HE onset and its progression because it is difficult to manage such patients. It indicates the need for liver transplant. If HE sets in and the more severe it is, you will need to consider early transplant. Death due to raised ICP and ALF is the most common reason. The second may be infectious complications, but the most common cause for death in ALF is due to the raised ICP. So how do you manage this hepatic encephalopathy? The pathophysiology of cerebral edema in ALF is not fully understood. Okay, there are several reasons that have been put forth. The most common is, inflammatory response to a circulating neurotoxin, especially ammonia. And there's impaired conversion of ammonia to urea in the liver, so that's why it accumulates and causes the raised cerebral edema. And there is a direct correlation, especially with acute liver failure, direct correlation to the value of your arterial ammonia. What we commonly do is your serum ammonia. But if you were to check the arterial ammonia, there is a direct correlation to the degree of HE, especially in ALF, not in chronic liver disease. Okay, so that's something that you need to keep in mind. And with the higher grades of hepatic encephalopathy, this could be the range of your ammonia levels anywhere between, depends upon the units, 150 to 200 micromoles per liter. Okay, it could be as high as that. So treatment of HE, the speed of rise in ammonia in ALF is too fast. So there is no osmotic compensation, unlike a chronic liver disease. So that is why they present with the raised ICP. And whatever treatment you give for chronic liver disease doesn't work for, ALF. So rifaximin, no. What about lactulose? No. There's high risk of ILS. So both are out. And this LOLA, that is L-ornithine and L-aspartate, what it does is it detoxifies the ammonia in the muscles. It converts it to glutamine. So that also there's no proven benefit. So there's no role in giving LOLA also. So then how do you treat? You have a raised ICP there, these patients are going to coma. How do you actually treat then the hepatic encephalopathy, which is the commonest cause for your mortality in ALF? You will have to think of your usual, this thing that you will do to reduce the secondary insult, reduce the cerebral metabolism, control your temperature, control your sedate the patient, maintain your carbon dioxide levels, maintain your glucose levels, maintain cerebral blood flow, I said, with vasopressors if required. If there is a rapidly worsening hepatic encephalopathy, then protein restriction may also need to be instituted. You can't have a normal protein that you would write in the chart, no, 1 to 1.5 grams per kg, that is not recommended. Okay, you may need to cut down. And osmotherapy. So osmotherapy would be your main weapon here to manage the raised ICP in hepatic encephalopathy. Both mannitol or 3% saline. 3% saline is better because these patients are at risk of HRS. So 3% saline in boluses would be the recommendation, targeted to up to 155. Mannitol can also be given, but again here your target osmolarity should be less than 320. If there is hemodynamic instability, mannitol is not recommended. Consider only 3% saline. Alright, renal replacement therapy could be the other best option for reducing your ammonia levels, especially when the levels are very high and it is indicative of severe cerebral edema. What about management of coagulopathy? Abnormal coagulation profile is one of the criteria for ALF, but are you going to correct? No, because there is the term called a balanced homeostatic effect. That means the coagulants and the anticoagulants, that is your procoagulants and your anticoagulants, are actually balanced out in a case of acute liver failure. So it is not indicated routinely to correct your coagulopathy. Okay, it can actually cause more harm than benefit. Only if there is a bleeding or you're going to do any invasive procedure, especially putting in an ICP to monitor the ICP, then only you need to give blood transfusion to normalize the coags. But the coagulopathy, otherwise I don't think you should be transfusing. TEG may be used in these instances, especially if you need to transfuse blood products. You can rationalize based on the TEG values and give the blood products. Infection risk is very high in acute liver failure. It's an immunosuppressed state, and sepsis in ALF has got a very poor outcome. So you need to maybe consider prophylactic antibiotics. But would you give prophylactic antibiotics for all cases of ALF? Is it one of the common prescription in the cases that you have managed? No. So there are certain, the EASL guidelines does mention prophylaxis only when there is a case of severe surge response, or there is a shock, or worsening, rapidly worsening hepatic encephalopathy, or you're considering for liver transplant. Only in such instances, yes, prophylactic antibiotics. So these are the treatable causes. I'm sure if I ask all of you, going to write down the antidote or the treatment for each conditions or causes for acute liver failure. I'm not going to enumerate this. It's available there in all textbooks too. Next, plasma exchange, another very important modality of treatment that is being considered in acute liver failure. How many of you do plasma exchange or plasmapheresis in acute liver failure? So not many of you are favoring. So what's the evidence? Okay, so let's look at it. It's actually, we are looking at high volume plasma exchange. It's not the regular volume that you would do for other conditions like thrombotic thrombocytopenic purpura or any other autoimmune causes. It's a high volume plasma exchange. What do you mean by high volume therapeutic plasma exchange? It's 15% of the body weight, that is about 8 to 12 liters of blood volume per exchange that you're looking at. Okay? So this removes cytokines and it improves transplant-free survival days. So that's the evidence from the 2019 writing committee for apheresis. And the 2019 committee for apheresis recommends it can be considered as a first-line therapy for acute liver failure, but I would say it definitely is indicated for acute liver failure in Wilson's disease, and especially with toxins, yellow phosphorus poisoning, that we commonly encounter, especially in metro cities where these patients are referred. And we have seen in our experience from our center, we see early institution of plasma exchange, especially with yellow phosphorus poisoning, has found to avoid the need for transplant. So this is probably one of the other modalities that you may need to consider. Renal replacement therapy, many of these patients in their course in ICU stay, there is a need for RRT because of the HRS is common, but there are certain indications. Only if there is acidosis or high ammonia levels, or there is high potassium, then you may need to consider. But the modality is very important. It's not your regular hemodialysis. What is recommended is continuous renal replacement therapy because it is stable hemodynamics, because these patients will have raised ICP, so you would consider a CRRT rather than a regular hemodialysis, and lesser metabolic fluctuations also, so that is why CRRT is better. So let's come to your medical management has kind of not doing good for your ALF patients, so you need to consider liver support system. That may become the need before you consider liver transplant. It's a bridge to your liver transplant. So there are two bridges, two methods that you can support a failing liver. So that's what is commercially available. So removal of the accumulating toxins, that is called as liver dialysis, or you can offer an additional metabolic support which includes hepatocytes in your filters to give some extra metabolic support. These are called as bioartificial livers. So these are the two supports. And when it comes to liver dialysis, the two commercially available systems are the MARS, or the molecular absorbent recirculating system, or the Prometheus, that is the fractional plasma separation and adsorption. I haven't used either of this. I think the liver centers, which are liver transplant capable centers, I'm sure they may be using. And these basically filter out the toxins. The albumin is used as a scavenger. The blood runs through an albumin cartridge, and this filters out the toxins. What are the toxins that it's going to filter? The bile acids, the pigments, the aromatic amino acids, or medium chain fatty acids, and cytokines. So that's what it's filtering. So I'll just show you, this is a MARS system. There are three circuits. One, there is a blood circuit. So you have a blood circuit, and you have your albumin circuit and the dialysate circuit. So the blood runs alongside the albumin circuit. So the albumin takes out all the toxins, and then rather than infusing albumin, replacing albumin, this albumin is recirculated. But because it has got toxins, it runs through the dialysate, alongside the dialysate circuit, which removes the toxins. So the albumin, the fresh albumin is, runs again through the blood circuit, alongside the blood circuit. So these are the three circuits that are there in the MARS system. Evidence for it is it improves the hepatic encephalopathy, but there's no mortality benefit for use of these systems. It's only a bridge to transplant. The bioartificial liver assist devices, as I have already mentioned, it uses hepatocytes, the human liver cells. It can be human liver cells, and what are the human liver cells? It could be the hepatoblastoma cell lines, or Porcine hepatocytes were also used. Okay, so these are more complex filtration devices. There's an increased risk of infection, but there's no mortality benefit. So the advantage for these systems are not too great. It's important to identify poor prognostic markers, because without that you won't know which are the patients who need to be considered for acute liver transplant, for a liver transplant on an emergency basis. Hepatic encephalopathy onset, as I have mentioned in the first few slides, is an indication for for liver transplant. Subacute ALF, even lower degrees, is a poor prognostic sign, needs to be considered for liver transplant. If there is extra hepatic organ involvement, that is, there's an ARDS or other organs are involved, it's another indication or poor prognostic marker. Unknown etiology is also another poor prognostic marker. Severity of the liver dysfunction in the form of how high your enzyme, how high your bilirubin, how severe your coagulopathy is also an important prognostic marker. Another marker that is being considered is factor V. Okay, factor V levels for a person who is less than 30 years, less than 20%, or if it is less than 30% in older than 30 years, is an indication of a poor prognostic marker. So there are prognostic criteria that are being used for prognostication of ALF. Early prognostication is very crucial. Okay, it is derived, but the unfortunate thing about these prognostic criteria are derived from historic controls. That means they're old cohorts and these prognostic criteria. We don't know what's the applicability, especially with the changing cohort of patients in the epidemiology. How applicable these prognostic criteria are of recent times is something that needs to be questioned. And we are all familiar with these two common ones, that is your King's College criteria and the BRiCC criteria. So this is the difference. If you see the King's College criteria, there's for paracetamol and non-paracetamol, and quite a number of criteria are there. Your pH, your lactates, your INR, the grade of your hepatic encephalopathy and creatinine. And when it comes to non-paracetamol, bilirubin, all those are also indicated. Whereas when you look at the BRiCC criteria, it includes only your hepatic encephalopathy and your value of your factor V. So that's the difference. Is one better than the other? It depends upon the etiology. So there are several other newer prognostic criteria that have come forth apart from the King's College. Let us take a few moments. Your King's College criteria, the BRiCC criteria, phosphate can be used, lactate, your alpha fetoprotein level, and sometimes even your MEL score also can be used for prognostication. But if you see for these more for paracetamol, the other criteria. But if you want to look at other non-paracetamol causes, I think these two still hold good. But if you see, the sensitivity for your King's College is quite low. Specificity is good, but sensitivity is poor. And for BRiCC criteria, it's not available. So you may need to put in all these factors to to decide whether these patients need liver transplant or not. So yes, liver transplant is a concern to get appropriate donor for the liver transplant, and ALF becomes a priority in the list for liver transplant. And the definitive contraindication for liver transplant is when there's raised ICP and severe brainstem dysfunction. Relative contraindication if the patient is in shock, multi-organ failure. There are some concerns of the type of graft. Since ALF is an emergency, many a times the availability of a donor is a concern. So often we get, we take in this marginal donors, meaning to say an aged donor, or there is already a fatty infiltration of the donor liver, but still we use it because it's a bridge until the patient's liver can regenerate. But in Asia, the cadaveric orthotopic transplant is still a non-availability. The availability is quite poor. So living donor liver transplant is the most common graft, especially in India or even in Asia. So to summarize, it is critical to take a good history and examine the patient. Etiology is something that we need to definitely look at, the staging, and for prognostication. So history and examination is very vital. Appropriate lab tests that needs to be done, we need to keep in mind, and identify potentially treatable causes for treatment. Multiple organ support definitely is needed, especially renal support, and to prevent progression of hepatic encephalopathy. NAT, yes, I think we need to consider for all cases of acute liver failure. Plasmapheresis, especially in cases of if you have patients with poisoning or Wilson's or autoimmune, it should be considered. Liver support system, especially in those centers that are capable of doing it, and it's only a bridge to liver transplant. Mars is the most popular. Liver transplant is the final option for many of our patients with acute liver failure. So it has been found that when you prognosticate using this criteria, many of the patients are avoided of a liver transplant and with good supportive treatment. So that is very, very vital. Thank you.